Dr. K. Narayani, who is the Journal Director Mumbai of Fortis Healthcare, came and inaugurated this center 2 days back. So our School of EUS, Nagi has seen it doubles up as a digestive wellness clinic also. We have some booklets we have prepared for giving information to patients, detailed history sheets. This is a sort of lab we have created for non-invasive tests.
Thank you, Vinay. Before I start, actually, I want to start by congratulating you and your team for this concept of digestive wellness clinic. I think this is a great concept because if you look at the clinics all over regarding wellness, they are general wellness clinics. You have sometimes cardiac wellness clinics, you have sometimes even pulmonary wellness clinics or metabolic wellness clinics, but it's very rare to have a digestive wellness clinic. And of course, preventive gastroenterology is a part of this. So I think this is a great concept, and I'm sure it will catch into the rest of the country also. The reason is, I think, very clear from what was known for many, many years. In fact, this is a stone from a Greek evacuation site where they found this. This was 2500 BCE. And you see what it said was that the writing there said that all diseases come from the gut. A healthy gut is a healthy individual, which is absolutely right. I know we are a gastroenterologist biased towards this, but I think there's a lot of truth which has now come in basically from studies that have come from the microbiome. For example, we know that the gut microbiome modulates all our activities, including all the physiological activities related to cardiac, related to pulmonary, related to even our neurological functions. And there is a great amount of data to suggest that simple things like depression may be related to gut microbiome. And for example, it's now believed that even the intelligence is related, and in the Nobel Prize winners, instead of looking at the brain, we should start looking at the gut microbiome, where they have a special gut microbiome which is resulting in this, in their innovations and discoveries. So I think we now very clearly coming back a full circle on the old Greek saying that probably everything originates from the gut, and in the gut we know that the most important dynamic factor is gut microbiome. So when Vinay asked me to talk on this, actually I went into the net to see what is this digestive wellness. If you believe me, not a single good article, not a single concept on this at all, which means it's a totally neglected field. But I think as gastroenterologists, we know that when patients come to us for a variety of chronic diseases, GERD, pancreatitis, cirrhosis and all, we're just putting them on some treatment and sending them off. We are not doing what I believe is a holistic medicine where all aspects are looked after. And of these, the most important, which is not listed here, which is a separate chapter by itself, is irritable bowel syndrome. I mean, any patient coming with gas, bloating and all is labeled as irritable bowel syndrome. And I used to think that, in fact, we used to pity some of our clinicians who are dealing only with this, but I found the truth that whatever practice gastroenterology, you may be a hepatologist, you may be a therapeutic endoscopist, but you will have to deal with these patients. Not only in India, all over the world. I've seen some of the top therapeutic endoscopists, their clinics, some of them have 40-50% of these patients who are actually labeled as IBS, functional bowel disease, and so on. But there is understanding of this which is still evolving, who require a different setup. Of these, I think microbiome manipulation is the most important. Now, microbiome studies are now becoming very mature. 16S studies to actually study the quantity of microbiomes, different genus which are there, and all that. It's become very complicated now, but there are many labs now starting to do this. In fact, I know a lab in Australia. The whole clinic is only microbiome clinic, nothing else. So I think this is a very important area, and I think what I feel is that this is going to become a part of Vinay's clinic also. Actually, looking at microbiome, culturing this, and also looking at different genus that is there, because we require a lot of data in Indian population. We don't have them. We are our diet is different, and diet, of course, has a direct correlation with microbiome. We have a cultural differences between West. Again, all of these contribute to a different setup of microbiome, and it's very important to study and stabilize this. And I'm sure this clinic you're setting up, Vinay, in future is going to be a standard one, which is going to set the baseline for all of these. And then we know that how we can manipulate this so that many of these so-called chronic diseases can actually change. In fact, many of the chronic diseases, like even cirrhosis liver, has a very close correlation with microbiome, and there is evidence that dysbiosis in these patients can give rise to decompensation, can give rise to increased onset of hepatitis C, and there is evidence that FMT, fecal microbiome transplantation, can actually dramatically reduce the encephalopathy in these patients. And of course, IBD we know is another one where, in fact, a large extent there is a neuropsychiatric part which has to be treated. So I think a wellness clinic would have not only a gastroenterologist and physicians, as Vinay has just shown, but also I think in future it has to be a more holistic, in the sense yoga teachers, I think those who are those who are teaching meditation, psychiatrists, all of them would be a part of clinic, and I think all of them coming together would result in our actually enhancing the digestive health. And we all, I'm sure about this old Greek saying, at least, that digestive health is a corner to our overall health, and there is a definite truth in that saying. Now, coming to the second part, I think there's more data on the second part, which is prevention of GI cancers, which I think is also going to be a very important part of this clinic that Vinay is setting up. Now, if you look at cancers, gastric cancers in general, you see that after pulmonary cancers, gastric, hepatic, colorectal are the most important ones. And these are figures all over the world, but also in India, we are seeing increasing rise of both pancreatic and colorectal cancers. So I think they constitute a very large fraction. And we now have, for example, a lot of studies regarding preventive aspects of, for example, lung cancers, breast cancers, cervical cancers, huge amount of data and huge amount of methodology which has been adapted in clinics everywhere. But unfortunately, not so for GI cancers. There have been sporadic, for example, in Japan, you have the gastric cancer screening programs. Similarly, in Western countries, you have the colorectal screening programs for cancer. But in general, they have not come into algorithms, and especially in our country. And this is very important. So what I'm going to review briefly, and this may be more useful for the postgraduates, is the principle of preventing gastrointestinal cancer, especially H. pylori gastric cancer relationship, Barrett's malignancy, hepatitis and liver cancer, colonic cancer, and pancreatic cancer. The 5 most important cancers which constitute the major cause of death or burden from GI cancers. And the principles of prevention, and this would be important for a clinic of prevention or a wellness clinic, is preventing the initiation of the carcinoma, elimination of the avoiding factors. For example, we know, and this is there for many, many diseases, smoking, alcoholism, obesity are linked with many diseases, including many in gastrointestinal tract. And most of the wellness clinics would be concentrating on seeing how these can be avoided. We also know that the secondary method of prevention is interfering with the metabolism of the carcinogen, or preventing it from reaching the target. And lastly, what we call by tertiary prevention is preventing the precancerous lesion from progressing to cancer. And in GI tract, there are many such precancerous lesions, including high-grade tubulovenous adenomas, precancerous gastric lesions, so on. So I think we have a huge area now here which you can exploit to this. So what I'm going to do is summarize the factors that can be changed in our population to decrease and prevent GI cancers. If you actually look at overall cancers, especially GI cancers, there are certain general features, and at this, I think all wellness clinics actually concentrate on this. High BMI, I think obesity is known to be associated with increased incidence, increased aggressiveness of the cancer. Of course, fruits, vegetables, oxidant sedentary lifestyle, smoking, alcohol. All of these are known factors, and as I said, any patient who comes into these clinics are counseled about this and asked to stop. I think it's important to remember that 30% of cancer deaths are due to these 5 behavior risk factors. So very simple. If we can alter this, we can alter a lot. Let's start with gastric cancer. In gastric cancer, we know that there's an association with Helicobacter pylori. Definitely, we'll come to that a little. Smoking, alcohol, high salt intake, and this is some of the things that we generally don't emphasize to our patient. We just say masala kam khana, but actually it's the salt intake. Emphasis on salt intake, those patients definitely are shown to decrease gastric cancer. Family history and vitamin C, again, another one which can be liberally given to our patients. And those both drugs and diet containing nitrosamines can give rise to cancer. So in gastric cancer, we have identified clearly pre-malignant conditions: chronic atrophic gastritis, intestinal metaplasia, H. pylori, and gastric adenomas. And the reason why this is important is there's a progression, a rhythmic progression into gastric cancer from normal to chronic gastritis to atrophy. It's believed that if you interfere at this stage, then we can stop further progression. But once it goes into intestinal metaplasia, then even interfere, you can't do anything now. There's been many studies showing this. So when you're coming to a wellness clinic, I think the gastroenterologist or whoever is looking at this patient is looking carefully in the stomach when they do an endoscopy to see if these patients, of course, in addition to biopsy and, like you said, endocytoscopy, we are trying to look whether we are beyond this stage or at this stage. If it's at this stage, I think we can definitely cause regression and prevention of gastric cancer. But if it goes into intestinal metaplasia, nothing much we can do. For gastric cancer, there are two different spectrums, both the distal cancers and the proximal cancers. Proximal cancers are associated with GERD and obesity, both preventable conditions. If we treat this vigorously, we can decrease incidence. Distal cancers are dietary factors, especially high salt, smoked fish, and so on, and of course, H. pylori. I think salt intake is something not emphasized. It should be, because many epidemiological studies in Japan and in our country also have shown that there's a direct association between salt intake and cancer. Of course, vitamin, I think even Vinay probably was involved in some of the studies when I was in Tata. Vitamin C consumption we know, and of course smoking is the most dangerous one. H. pylori is now classified by WHO as class 1 carcinogen. There is some controversy in this area, but I think this is a study published in BMJ sometime back which showed that H. pylori eradication therapy prevent gastric cancer in healthy asymptomatic individuals. This was a systematic review meta-analysis. Because a lot of times we argue in many meetings, should we eliminate H. pylori? It's not doing anything. There are no changes. But there is evidence that if you find H. pylori, you must do anti-H. pylori therapy because this meta-analysis has clearly shown that eradication decreases the incidence of cancer. And this is something that we would advocate very strongly. Which is, I think, number to treat 15 for Chinese, much higher for USA, but in India we don't have these numbers. And a clinic like yours, I think, should come into forefront in trying to resolve this issue. What is the extent of H. pylori eradication we require to decrease gastric cancers? Because adenocarcinoma is associated with Barrett's. We don't have so much Barrett's we thought, but increasingly we are seeing more and more Barrett's. And I think we don't have proper plan how to follow up these patients, whether to ablate them and so on. I think we need a lot of work in Barrett's in India. I think that has to come in. Liver cancer and hepatitis is something which is very well established. Hepatologists in our country have been doing great work in this. We know that both B and C can cause cancer, cirrhosis, alcoholism. But in my opinion, what is going to become the most important factor and what is going to become the most important factor for the wellness clinics is also this non-alcoholic fatty liver disease. We know that NAFLD is the commonest problem we face in general public. In fact, my assumption is the largest number of people walking into your digestive wellness clinic are those who are going to have fatty liver or fatty liver associated problems, NASH and so on. And we know that this can lead to cancer. And I think, in fact, you can have a whole clinic just devoted to NAFLD, and you'll be filled with patients because in our country it's extremely high. Of course, genetic and other factors. Hepatitis B infection is something that, of course, can lead to cancers, and we know that the viral load, E antigen positivity, all of them are factors which result in this. And we know that vaccination has dramatically resulted in decrease of this cancer. And we have data now, for example, from Taiwan, which has shown that just in 10 years' time, their carrier rates came down from, say, 20% to 1%, and HCC almost is eliminated there. I think this is very important. And then, of course, positive, and probably I think one of the things this wellness clinic would have to do is to have an emphasis on these vaccines also. I think this should become, in fact, I would suggest this to Vinay, that in your wellness clinic, you must have stock of vaccines, and vaccination, especially for hepatitis B, for example, should become a part of this wellness clinic. We also have other factors. Screening programs become very important, especially when it's cirrhotic, how to screen with ultrasound long-term in these patients, what to do, how to do alpha-beta proteins and newer markers that are coming now. And similarly with HCV, we know that use of antivirals has not only eliminated this, but also decreased the incidence of cancers in these patients. So both HBV and HCV therapies have markedly decreased incidence of cancers. But I believe still that the problem you're going to have is NAFLD. So if you have NAFLD patients coming into this wellness clinic, how do you advise them? Both in terms of exercise, in terms of diet, in terms of smoking, other factors, but more importantly, following them up to see that they don't land up in cirrhosis and ultimately cancer. I think this is going to become a very important part of the wellness clinics, because this is what is going to be the main feature that we see. And we know that there are some modifiable factors. For example, you can't choose your parents, unfortunately. They're modified, but lifestyle, alcohol consumption and all, which can become, I'm sure, in the clinic, you're going to have counselors who are going to discuss about alcohol, smoking, and so on. So we can do lots more to this space. Enough education and awareness are the key problems, I think, and this is very, very important. And I think also one of the things, in addition to the psychiatrists, the yoga teachers, the meditation teacher, counselors, you must have educators as a part of this clinic, because they are the ones who would sit, talk to the patients, educate them, show them charts of how obesity and metabolic syndrome can lead to NAFLD and how this can go further on. I think this is a very important part. In fact, you can have group classes, because I think you have a mini auditorium there which can be part of this, so that cancers that we don't concentrate on, unfortunately, we're seeing increased incidence of this is colon cancer. In the Western world, there is increasing incidence that, for example, colonoscopic screening and removing polyps have decreased left-sided cancers. A lot of evidence left-sided. Even right-sided, there is decrease, but not so much. In fact, Sydney Winower, way back, about 30 years back, started this work. And now, it's, I think, colonoscopic screening has become a routine part of their work. In fact, the major part of GI work is this. In our country, it's still not a problem, because we believe colorectal polyps are not very high. We're just doing now a prospective study in our unit where, surprisingly, when you do a prospective study, we find that 5 to 6% of the population, not as high as in West, where 30 to 40%, still 5 to 6% of our population seems to have colorectal polyps, and from there we are starting to get colonic cancers. Of course, in the West, anybody above 50 years, history of first-degree relatives, and so on, or those with HNPCC would have to have colonoscopies done frequently in terms of screening. We haven't formalized that, and one of the things that this clinic should do, Vinay, I think you should actually start having guidelines of how we should do our colorectal cancer screening programs, whether to use FIT in our patients or go for only sigmoidoscopy or go for colonoscopy. I think we have to give a lot of guidelines, and this becomes a very important future area. For example, we know that for colorectal cancer also, physical activity causes 24% reduction. Obesity, smoking, alcohol causes increased this. And then we show the intervention with aspirin, NSAIDs also, and eating high fiber diet, low meat diet can cause a lot of difference. So I think colorectal cancer risk assessment becomes very important in these clinics, and I'm sure many of the clinics will start looking into this, and your clinic probably will have charts like this, when to start doing screening colonoscopy, 50 years for average risk, but those with a moderate risk, especially those with high family history, should get earlier, even starting at 40 years. So we have a lot of colon cancer syndromes. And again, don't want to go into the details of this, but we also know that after we detect a polyp, for small rectal polyp, a repeat colonoscopy would require after 10 years. 1 to 2 small, 5 to 10 years. If there are more than 3 adenomas, villus, high-grade dysplasia, 3 years, and so on. All these are now not a part of our routine screening procedure. As gastroenterologists, we don't go into this, but I think we should. And in the wellness clinics, these charts will become very important as a part of this preventive clinic. And of course, we have to see, also we know that for proximal CRC, although it's less effective for distal, we definitely know that screening colonoscopy can make a lot of difference. And we also know that small things like diet, exercise, smoking, certain supplements, and daily aspirin intake can decrease the incidence of colorectal cancers. And these are all things that in daily clinical practice we don't emphasize to a patient. If you have a separate wellness clinic, this is where they get proper advice on this. So guidelines are there for all the diseases, but putting them into practice is important. And putting them into practice in our country where these are not still established becomes very important. And this wellness clinic is going to play a role. And finally, coming to pancreatic cancer, unfortunately, we are seeing more and more of this. We know that most of them come at a late stage, but primary prevention again is largely non-specific. Smoking, obesity, diabetes, chronic pancreatitis as a family history, I think you should actually look into it. But obesity is very, very important. And this is an area I think it becomes, worrying to the patient when you go on repeating. But if we show them charts like this, where obesity causes even pancreatic cancer, they know what's the problem. There are certain hereditary pancreatitis and hereditary pancreatic cancer risk. For example, people in families with breast cancer, there is a definite evidence of increased pancreatic cancer, and they have to be screened at least by CA99 in these patients. Pancreatic cancer surveillance is more difficult. Of course, the role of endoscopic ultrasound, Vinay is an expert in this, coming in the several guidelines that have been put into this area. And finally, before I end, I like to show you this picture that what happens sometimes is that this cancer screening, cancer awareness gets exaggerated in the press. In fact, Jack Andreca was a teenage prodigy who was supposed to have found a method to detect early pancreatic cancer. This was in 2014. He was given this grand prize. His article was not published. And he was invited everywhere. He gave TED Talks. Obama invited him to the White House. He had dinner with Michelle Obama, and he became a big star. 6 years from now, his study has never been published. There's never data coming in. And all this became just a hype, and people were told that a new diagnostic test to detect the pancreatic cancer is coming, but we know that this is not there. So unfortunately, in most cancer detection or cancer prevention, this sort of hype is coming in. And I think it's a duty on our part as educators, as part of this wellness clinic, to educate our patients in a proper way. So this education includes a sound knowledge of factors associated with GI cancers, interventions needed to be executed. And as I said, awareness and education is the key, and very common risk factors: smoking, obesity, diet, physical inactivity. You don't require to have knowledge on this, but we know that these reduced cancer burden by 25 to 40%. And these are small, important facts that can be driven through in clinics like this. And once again, Vinay, thank you very much for giving this opportunity. And I'm sure this wellness and preventive clinic that you have started is going to be a big success. And I can see a lot of things that it can do. Thank you very much.